Hi, it's Dr. Centeno, and thanks so much for joining me here at You've Got the Power. Today we're going to talk about sort of an interesting topic. We've been seeing more cases of DMX showing that the C1 or bone or atlas tends to flutter or jump in some patients. Now, that's something that patients have described to me for years, that it feels like their C1 is jumping around, my CCI or craniocervical instability patients. But seeing that on DMX is another thing, right? Because it allows us to say, wow, that is jumping around. So we're going to look at that today, see what it looks like on DMX, and then talk about what ligaments in this particular case that I'll show you are likely involved and likely need to be treated to get rid of that problem. So that's what we'll talk about today. Usual thing is that I do a short presentation and then we'll go to questions. You can ask questions about this topic or really any topic at all. So again, today we're going to talk about C1 or atlas flutter, or where the C1 is jumping around. That's something that patients for many years have told me is something they feel in their neck, craniocervical instability patients. But we've been seeing it more on DMX, Dr. Katz and myself, and we've been able to document a few of these that are pretty interesting to see. So I'll show you one of those cases, and then I'll get into an analysis of which ligaments are involved. So let me go ahead and share my screen here. Looks like that worked. And then we'll start with a presentation here. You know, I may set this up because my screen is so wide. I may set this up a little differently here, so that I can show you just the full presentation. So let me try that. I'm going to switch the share around here. So let me output that first. Okay, looks like that worked. Then we'll get into the screen sharing and just show that window. That's better. So before I get started, I do want to give a warning. You know, one of the things that's difficult for any physician that does procedural work to keep up with is the new stuff that's being sold on social media platforms. Now, there's lots of things I've talked about, BPC 157 being an example, and a long, long list of peptides. It's anyone's guess as to whether any of that stuff will help your healing, but at least it's not causing, or at least based on what I know, who knows, it could be, but at least it's not overtly causing my patients to be at greater risk during a procedure. But before we get into today's presentation, I do need to give a warning about Kratom and then CBD, CBDA, CBG, CBN, CBV, because these are becoming a bigger issue. You know, Kratom is something that sort of has been in my periphery. I knew what it was. I knew it was out there. There was a big splash in 2016 where the DEA tried to schedule it. Then advocates pushed back, and then it kind of never got scheduled. But what I'm starting to see is, as you know, we had things like THC and low-dose naltrexone that were pushing our patients into dangerous situations with regard to anesthesia. So both of those will dramatically increase anesthesia requirements, which just causes all sorts of problems, increases the risk to the patient. But Kratom is one I think that's it's becoming a bigger deal as time goes on. So we had a case this week where it was extremely difficult to put the patient to sleep. We were at lethal doses of anesthetics. and we still couldn't get the patient completely asleep. Thankfully, I've done enough of these procedures where I was able to safely get the procedure done, not without increased risk. There was increased risk because anytime the patient moves, there is. But I've done a lot of these, so I was able to get that done. We were going to do an anterior neck ALL, but the patient was moving around too much for it to be safe, so we had to take that off. And only after the fact did we understand that this patient had been taking Kratom. And so that caused me to spend some time digging into this psychoactive drug. It's not an herbal supplement. It's a drug. Let's face it. It's a drug no different than any of the drugs that are derived from plants. Same thing with THC. It's a powerful drug. So for Kratom, the biggest concern is that it acts at opioid receptors. And opioid receptors are narcotic receptors. So it's basically, for all intents and purposes, a powerful narcotic. And because it acts at those receptors, in 1 year from 2016 to 17, there were 90 deaths associated with Kratom. How did people die? The same way they die overdosing on heroin or fentanyl or anything else. You take too much of it, it suppresses your respiration because it acts at those same narcotic receptors, and you stop breathing. Listen, at the end of the day, I don't really have a position on what people take to manage their pain. If Kratom works better or if THC works better, that's fine. But where I draw the line is when these drugs start interfering with the safety of procedures like PICL or any other procedure we do. Because patients are taking them, we're having to give lethal doses of these medications just to try to keep the patient asleep, which then increases the risk of harming that patient with anesthesia, or the risk the patient is going to be harmed because they're moving during the procedure. So we know this happens with THC. We know this happens with low-dose naltrexone. There's some data coming out now as of 2022 that it also happens with Kratom. Makes sense. This is an opioid narcotic that's unregulated at this point, regrettably. And again, I don't have a position on what you use to manage your pain. You can use whatever you want. But when it starts to increase the risk of the procedure is when there's a problem. And in addition, all of these CBD derivatives likely also do the same thing or act similar to THC in that they increase the amount of medications that we would need to use. So at the end of the day, just making sure that everyone understands this, we're going to now start to put this in our paperwork because this is becoming a bigger deal. What makes me wonder is how many patients we've seen over the last year or so that were taking Kratom without our knowledge. And as a result, we had a very severe issue putting them to sleep and keeping them asleep. So again, how long, if you're taking this, how long should you be off? Nobody knows. This is all very new stuff. We're just starting to see publications on the anesthesia risk come out. Again, Kratom was a 2022 publication. So no one really knows how long you have to be off of this. My guess is at least a couple of months. But again, it's like anything else. You can be on any of these drugs. These drugs don't cause the procedure to fail, based on what I know. They just make the procedure itself higher risk. And they also markedly increase the risk that you won't be able to manage your pain after the procedure, especially Kratom, because it's operating just like a narcotic. At the same exact receptors as heroin, as the same exact receptors as fentanyl, the same exact receptors as morphine or oxycodone or or hydrocodone or hydromorphone. So just wanted to throw that out there. I will bring this up a couple more times here over the next few weeks to make sure that everyone understands what the issue is. So today, getting to the topic that we had planned, talking about Atlas Flutter on DMX, or when the Atlas sort of jumps. And this has been something that my CCI patients have described to me for years. Sometimes it feels like their Atlas is shifting or literally jumping, or at least that's how it feels to them. And Dr. Katz and I have been catching more of these on digital motion X-ray. And he was actually the one that showed this to me initially. So we'll go over that case today. So again, this has been a constant report from patients. So the question is, can we see it on DMX? I don't expect that we'll be able to see all of these on DMX, but we can see some of them. So this is the what I want you to watch here, and this is Dr. Katz. And you're going to see as this patient comes back up that the Atlas here kind of jumped. It went suddenly down much more quickly. So I'll play that again and watch up in here as the patient extends. Boom, it just jumped down there. So again, let's watch that. Boom, Atlas goes again. I'm gonna do it one more time here. So we're watching up here, and we're going to see as the person extends, this Atlas or C1 suddenly shift downwards very quickly. Patient's head will go into extension. Boom, you see that C1 shift down. So, what are we seeing there, right? If this is the patient's Atlas and this is C2, this is what we're seeing. We're seeing it suddenly go down in the back and suddenly shift up in the front. And that, again, fits what I've been hearing my patients talk about. My Atlas jumps around. It feels like when I'm moving around, I can feel my Atlas jumping or shifting or moving. So if we do a quick analysis of the ligaments involved here, it's not that hard to figure out what's happening. So let me see if I can get a pen here. Hopefully I can, although I may not be able to in this mode, regrettably. Which ligaments would be responsible? Well, the front of C1 goes up. The back of C1 goes down. So the back of C1 going down is going to be primarily the posterior atlanto-occipital membrane here, which is a deep one to inject. It has to be injected under X-ray guidance with contrast confirmation. And then the anterior longitudinal ligament here would be another one that's holding C1 down. So if the C1 on your left there goes up and on the right goes down, those are the two ligaments. Now realize there's also a component in all likelihood of the cruciate ligament, because it wouldn't be able to shift like that if the C2 dens were firmly attached to C1. So that's that transverse ligament, or really what it represents is the transverse band of the cruciate ligament that binds those two together. So if that's not firmly bound together, then you're going to see it be able to shift like that. If it were firmly bound together, it wouldn't be able to shift like that. So again, getting into what kind of injections would that be, that's going to be a more advanced posterior injection if we're just talking about trying to get that PAOM. But if we're talking about getting the transverse ligament, which is really something that has to be loose to allow that motion, then we're talking about that PICL injection from the front. So let's go ahead and take some questions. That was just a short one, other than my little lecture on Kratom and how dangerous that can be for patients doing these procedures. Regenix, I'm going to advance by DB. What would be the best supplement I could take orally from massive inflammation, upper abdominal pain, a GI, and a heart test came back normal? I'm not quite sure I can advise you on abdominal pain because I'm not a GI specialist. A good anti-inflammatory oral supplements include things like turmeric with bioperine, EPA fish oil or EPA omega-3s, and glucosamine chondroitin. All of those have been studied against nonsteroidal anti-inflammatory drugs in randomized controlled trials and shown to be pretty similarly or more effective than those drugs. Andy, question about C0C1 injection technique. Previously on live, you said needle is aimed above the visible joint line in the center of the joint. Your paper, you say the posterior lateral edge. No, it's above the visible joint line. Not quite sure what you're referring to as far as posterior lateral edge there, Andy. But again, these are not procedures that you should be trying to learn on Facebook Live. These are fellowship training only procedures. So that would mean that you've already done some fellowship training in interventional spine. You've been out there a number of years and you've gotten those needle skills down. So you went to medical school, you did an internship, then you did a residency, then you did a fellowship in interventional spine. Then you practiced a couple of years, got your needle skills to a high level, and then you spent additional time in either another fellowship or with some hands-on training on how to do C0C1. But definitely not something to learn over Facebook Live. That's just dangerous and inappropriate. Michael, with mild symptoms of CCI and no history of serious traumatic injury, should I risk the radiation exposure of a DMX? I'm worried I have CCI, but don't know if I do compared to others' symptoms. I think the best place to start if you have upper cervical symptoms would be a hands-on physical exam that has no radiation exposure with someone who can delineate whether or not there's an upper cervical component to what's going on with you rather than a digital motion x-ray. Debbie, would this cause chronic dizziness and memory issues? Upper cervical problems, like the one we just looked at on DMX or craniocervical instability, can cause chronic dizziness and memory issues or, quote, brain fog, among other symptoms. Regenetics mid advanced by Sherry Scott. I feel that all the time. Is this something PICL can fix? If that is something we deal with, should be wearing a collar for safety if it's not dangerous. I don't think it's I don't think what we saw is dangerous, but certainly tightening the transverse ligament and some of those other ligaments that we talked about should be able to fix or help that problem. Amen. Hey, Dr. Centeno, does pressure in the ears and ringing always mean arteries, veins, compression? No, there's lots of other causes, certainly of pressure in the ear. There are certainly other causes of ringing in the ear. So again, you know, like with many of the things that we see, there's crossover to other diagnoses, and those really bad things get ruled out. So for instance, some of that might happen with a vertebral artery dissection. You know, all of that kind of stuff needs to be ruled out. And then we get into saying, okay, are these upper cervical related issues? So for instance, for tinnitus or ringing in the ears or pulsatile tinnitus, we know that craniocervical instability, as we've talked about here, can cause intermittent compression of the internal jugular vein. So if we see that in addition to instability, we can say, yeah, that makes sense. That what we're seeing on this image seems to cause the symptom that you're reporting or is likely associated with it. Susan, I've been getting my atlas adjusted before I get the PICL. The adjustments have made my symptoms worse. I'm extremely off balance to the point of tipping over, bad head pressure, etc. Is this normal for atlas adjustments in the beginning? No, not normal. It generally means that either you're not a good candidate for that kind of treatment, or they're using the wrong adjustment vectors. So I would definitely stop if that's what's happening. Chris, are intrathecal stem cell injections valid safe treatment for spinal cord and brain injury? Seeing a lot of overseas clinics offering these treatments. No, they're not. Listen, The biggest problem with all of these overseas clinics, or what I call the Banana Republic clinics or the Asian clinics, is that the interventional skill to do intrathecal injection is very, very poor. Meaning that here in the United States, that would be done in a several $100,000 injection suite. You would have a very experienced provider place that needle in through the dura. There'd be a small amount of contrast that would be injected, showing that you have intrathecal flow. And then that would be chased with whatever you would intermittently put in contrast to make sure that the areas you were trying to cover with your intrathecal injection would be covered. That's almost never done in these Banana Republic clinics, Mexico, Costa Rica, etc., because the local docs don't do it that way. They just stick a needle in there blindly. If they get some what looks like cerebrospinal fluid back, they inject. So no, that's not safe. That's not effective for treating that type of issue. I would not go to a Banana Republic clinic to get that done. Robert, are there efforts to reaching med students about CCI alone, its symptoms, etc.? I think med students would be too early for that type of interaction. I've certainly now lectured quite a few times in front of both chiropractors and interventional orthobiologics specialists about craniocervical instability. So that's the place, I think, to do that education. And we're seeing more of those providers get smarter about this. So we're now seeing more of those providers start to recognize that CCI could be an issue. They're then sending those patients to us in Colorado to be evaluated. So that's getting better and better as time goes on. Now, the next step would be getting it in front of other providers, the average spine surgeon, for example. That one's probably going to be a little harder to pull off. Strange. I'd like to see how soon can we do clockwork exercises after PICL? What is the exact scale size of the clock? That is very dependent on the patient. So if we're starting with a high functioning patient, then they can start that as soon as they feel better from the procedure and everything goes back to normal. And then for the most of our patients who are not high functioning, meaning they're not working out on a day-to-day basis and maintaining their health by working out on a day-to-day basis because they can't, then they're going to have to be individually approved to start those clock exercises. And the scale of the clock is about the size of a poster, but we move the patient closer to mid-range away from or far away from the clock to change the amount or the excursion of the head. Forever Young, what's the difference between a frozen shoulder, shoulder impingement, rotator cuff tear? Do they fall into shoulder instability umbrella, or instability is different? Yeah, a bit different. So a frozen shoulder is when the capsule is tight and you really have no range of motion or very little range of motion. Shoulder impingement is you generally have pretty good range of motion, but the bursa or the lubricating sac is getting impinged or beat up and is swollen and painful. Rotator cuff tear would be when the rotator cuff tendons that control shoulder movement, one or more of those gets torn. And then instability would, in the shoulder, at least the big shoulder joint, would be when the ball and socket, the ball is unstable in the socket. So different concepts all. Jay, got the PS procedure done last week from Dr. Centeno, feeling really good and looking forward to healing taking place. Well, great, Jay. I'm glad you're feeling better and recovering well. Regenix, advanced by Gerald. If CCI is suspected, what procedures should we have to rule out other things before we consider your PICL? A lot of that depends on what's causing CCI. So that diagnosis has to be made first. then we can figure out what type of procedures might be effective. So for example, if it's a 3A type instability, which is anterolisthesis of 2-on-3 inflection, then simple posterior ligament injections usually work well. If it's type 2B, where we have an alar ligament problem, those kinds of injections aren't going to work well, and we'd have to do that PICL. So I think you're misunderstanding as far as posterolateral edge of the joint. What's being described there, Andy, is different than that, but I'm really not going to continue to discuss fellowship-trained, highly complex medical procedures in a Facebook Live. So I want you to change the subject, or if you don't have any other questions to ask, then those questions would be inappropriate for this type of setting. Finn, are there any other interventions for ligament repair on the horizon you're interested in? For example, diets or infrared sauna, bone broth collagen? No, I don't think any of those are going to work for ligament repair. Ulysses, do you think thoracic instability also cause forward head posture in the neck? I mean, that could be one cause of a forward head posture, but usually that wouldn't be the main cause of a forward head posture. Finn, does ligament tightening by PRP or stem cells alter the alignment of the atlas? For example, could tightening reduce compression of neurovascular bundles by unstable upper cervical? So two different questions there. The first one having to do whether or not tightening ligaments could improve alignment of the atlas. I think you're talking about static alignment. So there are two different concepts. Instability, which would require ligament tightening, is a dynamic concept. So we can only define that by looking at how things move. So our goal there is to improve the excessive motion. As far as the alignment of the atlas, that's going to be a static concept and one not usually associated with instability. And then the separate question, which really doesn't fit with the first one, could tightening of those ligaments reduce compression of neurovascular bundles? And that would be the idea behind tightening those things. Duck P, question about POTS and EDS. Why does prolonged standing more than 4 hours flare me up a little bit, but exercising doesn't? Yeah, that's a good question, Duck. I'd need to know more to answer that one. Chris, so assuming intrathecal stem cell injection is done properly, you said, is the treatment valid, safe for spinal cord injury? What about CSF leaks? I don't know of any data that says it's valid and safe for spinal cord injury. Haven't looked at that literature in a couple of years, probably 3 or 4 years ago was the last time I looked at it. At that time, there certainly wasn't any data that it was, quote, valid and safe, meaning safe and effective. What about CSF leaks? That wouldn't be a treatment for CSF leaks. If anything, you would want to inject epidural rather than intradural there. Ulysses, when ligaments get stretched out in the neck, it also gets stretched out down the whole spine too. Could happen that way. Levon, hydroxysteroid is bone marrow eventually regenerate post bone marrow aspiration? Would there be the same amount of bone marrow for the next PICL? The answer is yes. We did that study 4 years ago, 5 years ago, something like that. And the answer is that if you are a male or female, if you're a male of any age or a female who is below age 50, then the answer is yes, relatively quickly, certainly within 6 months, but probably more along the lines of less than 2 months. If you are a female over the age of 50, then there may be issues there within the 6 to 9 month range. And so that means that if you did a bone marrow aspirate procedure one way, You would want to change up that bone marrow procedure to a second different method to maximize stem cells if you had done that procedure within 6 to 9 months of the first one. Bonnie, with head eye pressure, stated cause could be swelling of dens bursa increasing, intracranial hypertension. Have success with treating this. We inject small amount of steroid into bursa. I think the question is, can swelling in the dens bursa cause head pressure? Yes, we believe so. As far as injecting a small amount of corticosteroid in there, we could do that, but we would really get the same effect by using something like bone marrow concentrate or platelet-rich plasma. And putting corticosteroid into the bursa may have long-term impacts on the bursa and the surrounding tissues. Ulysses, do you inject or did you do a PICL procedure yesterday, and how did it go? Did I do a PICL procedure yesterday? No, not yesterday. I did PICL procedures on Tuesday and Wednesday. They went well. Finn, is there any anterior translation of C1 at night? Could PRP, C12 facet, and the nuchal ligament help, or you definitely need C0 alar transverse if causes of ligaments unknown? Finn, there could be anterior translation of C1 at night if it wasn't firmly attached there. We would just need to look at what firmly attaches C1, right? One of the big firm attachments for C1 would be that transverse ligament. Another would be 0-1, all of the anterior ligaments, as well as posterior ligaments to C1. So the anterior ligaments would be SAAOL, the AAOM, the tectorial membrane. The posterior attachments would be the PAOM, the vertebral dural ligament, and then supraspinous ligament. So if you got the outside ligaments from the back, you'd have some effect, but probably not a lot. If you got all of the front and back ligaments, you would have the maximum effect. As far as injecting the facet joint at 1-2, it's probably going to have little impact on the atlas moving forward. Ulysses, why do providers use PRP for 1-2 joint than prolotherapy? I'm not sure what you mean by that one. Maybe if you could elaborate a little bit on that one. Faction, some HEDS patients describe being told they have C1C2 hypermobility because of ligament laxity, but not CCI. Is it possible for the doctor to draw that line? Has the patient? I think, Faction, what you're trying to state here is an important point. And that is that there's a difference between having C1C2 hypermobility and having symptoms from C1C2. And in fact, I just had this conversation with a patient that we did a telemedicine on this morning. This was a patient who clearly has type 2B CCI on the DMX, which is the lateral overhang type, but had some symptoms that didn't really fit classical CCI. So I had to tell that patient, listen, I don't know if what we're seeing on your image is what's causing your symptoms. And in order to increase the likelihood of that, there's a few things that can happen, right? As I told this patient, let's say we've got a hypermobile patient who is getting out of a car and whacks their head really hard. And all of a sudden they start to get headaches, dizziness, imbalance, pain in the upper neck, some visual changes and brain fog. And that happens within a day or two. And then eventually they go see an upper cervical chiropractor and all that stuff is made better temporarily. And they put on a neck collar and it feels better with the neck collar on, and a lot of those symptoms go away. In that situation, we've got fairly high confidence that their C1C2 hypermobility that we see on DMX is causing their symptoms. Now, if we take that another situation, and we have someone who doesn't have EDS and someone who didn't have any head trauma and someone who has atypical symptoms. So they've got some brain fog, they maybe have some achiness in their body, not a lot of headaches, not a lot of neck pain, not a lot of imbalance, and maybe they've got autonomic symptoms. Now we're not really sure that the instability we're seeing is causing their symptoms. So that's a key component you're bringing up there. Just because we see the instability doesn't mean it's causing your symptoms. It's been advanced by Sagatu. I'm not really sure if this has been asked before. Is it true the vagus nerve can damage from untreated, or better said, misdiagnosed instability, or maybe be damaged? I'm in Australia, and the ailment of the neck are very poorly understood without getting much into it. If that's the case, other ways vagus nerve damage can be prevented or minimized until we get some help. Yeah, so the answer is nobody really knows. My sense would be using a collar if that helps you, only when you're active or in situations where things might get irritated, but realize the more you use a neck collar, the more likely there is to be significant atrophy, and that could make the problem worse. As far as vagus nerve stimulators, we were trying a few of these. Wasn't overly impressed from the trial, but maybe it's certainly possible. And there was recently a trial in rheumatoid arthritis patients for vagus nerve stimulation, and this was an implantable stimulator. And the trial had negative results. So I'm not convinced that a vagus nerve stimulator is the answer. Other options might be to try to find an upper cervical NUCA or AO chiropractor who's local, who can keep things in place as much as possible. Ulysses, stabilizing thrusting and shoulder can help forward head posture. Maybe. Ulysses, can the VDL be safely injected? Yes. Not a problem. Ulysses, I saw a lot of providers use PRP for 1-2 joint instead of prolotherapy. Yeah, I think the biggest problem with injecting prolotherapy is that prolotherapy solution is in general hypertonic. So for example, someone had talked last Facebook Live, I think it was, about some provider who was injecting a venous sclerosant P2G at 0.1. And the problem with that, or prolotherapy at 1-2, is that if you were to inject that stuff into the vertebral artery, that's going to cause a certain brainstem stroke. No questions asked. If you were to inject PRP inadvertently into the vertebral artery at 1-2 or 0.1, as long as it's a high quality PRP that doesn't have any clots in it, it's probably no harm, no foul. Or at least it's much less likely to cause issues. But injecting a sclerosant or a hypertonic substance like 12 to 15% dextrose into an artery is an awful day for everybody. So that's probably why you see that being done more often that way. Bonnie, have you had success shrinking size of a dense bursa with PRP, thus reducing head pressure? Could that depend on the time the bursa has been there? Yes, suffice it to say that when we treat the instability, which causes the bursa, we have success in getting rid of the head pressure. As to whether or not the head pressure was causing or being caused by the dense bursa, I don't know that we'll ever know that for sure, but realize the bursa is usually swollen because of the instability, so the treatment is really getting rid of the instability. Finn, if CXA is low and neutral and reduces further on both flexion and extension, which ligaments are lax? Finn, I think you mean to say if the CXA is low and gets smaller in flexion, it would always get bigger in extension. I've never seen a CXA get smaller in extension because that wouldn't make sense unless you may be doing something like this. You're not doing an actual extension maneuver. But as long as the head's going back, the CXA is going to get bigger in extension. And then which ligaments would be at play there? The tectorial membrane from the front would be one of those ligaments, as well as the posterior ligaments, which could include the PAOM, like we just discussed, the VDL, supraspinous, interspinous ligaments. Caleb, have you ever seen a hypermobile EDS patient with damage only to the posterior ligaments that did well with posterior PRP at your clinic? Sure, yeah. In general, for that issue, we would tend to use more prolotherapy augmented by platelet lysate or bone marrow. In general, in my experience, hypermobile EDS patients don't do quite as well when you inject PRP into their ligaments. It's usually hypertonic dextrose with platelet lysate or bone marrow concentrate. Dynamic, unreal. I don't think I have EDS. I didn't have any blunt force trauma, but I did put repeated stress on my neck for years. I have every single symptom on the Wikipedia page for CCI, sometimes severe. Yeah, just realize that I think what patients get confused about oftentimes here is that we're talking about the upper neck producing those symptoms. So you don't have to have instability to have many of those symptoms. So headache, imbalance, brain fog can be produced by a pissed off C2-3 facet joint, a pissed off C1-2 facet joint. You don't have to have any instability at all. Those joints just have to be injured to produce those symptoms. So you may just have what we would call a craniocervical syndrome. So a craniocervical syndrome just means that there's something in the upper cervical spine producing the symptoms, but there isn't any instability. Ulysses, not every provider will use PRP for C1-2 hip. For example, Ross Hauser used prolotherapy as we do with the Hackett technique. Yeah, I think as we've talked about here, Ulysses, injecting prolotherapy anywhere near that vertebral artery is just not appropriate. And so in order to do that injection at 1-2 or 0-1, you would need, number one is you need, interventional spine training, which these days is fellowship training in interventional spine, then a bunch of additional training, then a bunch of experience, then CRM fluoroscopy, then digital subtraction angiography. So you can't just use an X-ray unit to kind of put the needle someplace up there or try to use ultrasound to do that injection. So I think we've talked about that one before. Finn, given the transverse ligament is the strongest ligament, is there any laxity? Does this always suggest trauma? Not sure what you mean there. Do we see patients with transverse ligament laxity? We do, despite it being the strongest ligament. Caleb, I know you talk about providers claiming to target joint capsules, but couldn't subjectively experiences vary amongst different patients. Some can be unbothered while others feel joint is unstable. Not sure what that question is. So maybe rephrase that because I'm not sure how to answer that one. Ulysses, is kyphosis related to scoliosis like instability? Kyphosis and scoliosis are frequently seen together. That's called kyphoscoliosis. Dynamic, is there any treatment for craniocervical syndrome? How's it different treatment from CCI? Sure, yeah, you identify what the structure is that's causing the symptoms and you treat the structure. No different than CCI, where you identify which ligament is causing the problem and you treat that ligament. So same idea, same set of concepts, same set of injectates. The need for imaging guidance, as we always discuss, and high levels of experience in the upper cervical spine. All of that still applies. It's just treating a different structure. To clarify, are lax or damaged transverse ligaments always caused by mechanical force trauma? No, we certainly know that we see transverse ligament laxity, for example, in non-traumatic scenarios like rheumatoid arthritis. So it doesn't have to be mechanical force trauma, but that's a common cause. Levon, can type 1A and type 2A instability cause insomnia? Yeah, Levon, if you look on the Regenix website on the blog, and if you just type in apnea CCI, APNA or APNEA, apnea, and CCI, that'll come up. There's a whole blog on that concept that upper cervical instability can impact the airway, and that can cause mechanical sleep apnea, which can cause problems with breathing, and then that sudden awakening that happens when you're apneic, when you're sleeping. So that then leads to insomnia. Okay, guys, any other questions I can answer here? I've had a bunch of great questions today. We were talking today about why does C1 jump in some CCI patients, and can we see that on DMX? I showed you one on DMX. We've been seeing, Dr. Katz and I have been seeing more of that as time goes on. Any other questions I can answer? Again, I just wanted to shout out about the concerns we have regarding patients taking, in particular, Kratom prior to a procedure. This is a naturally derived narcotic, and so it operates at those narcotic receptors and can create some very severe issues with anesthesia that are just now starting to get reported in the peer-reviewed literature by doctors who are having problems. In fact, I was reading a case this morning which was super duper scary. They gave this guy, let's see here, I think it was some psychotic amount of medication. Anyway, I can't find it right here, but long story short is they gave him probably a 3x lethal dose. Still wasn't really. And then obviously the guy had extreme problems with post-op pain, post-op agitation, probably due to withdrawal from Kratom. And then he was a bear to manage post-op, which is pretty much what we see in patients that are on these things. Dynamic unreal, the damaged structures involved in cranial cervical syndrome can also be treated by PRP injections. They can, once you identify the damaged structure, which is really the key. Ulysses, do you recommend supplements to patients? We do, depends on what it is we're trying to accomplish, but sure, yes. Caleb, rephrase, the torn facet capsule can be no issue for one patient as long as the inside of the joint isn't inflamed, painful, while a torn capsule another patient causes a feeling of looseness. Yeah, I think what you're bringing up there is the classic problem that we always see, right? We have this issue of we can take 10 different patients with the same exact MRI or DMX findings. Some of those patients are going to have pain, some of them aren't. So all we see in these findings is an increased risk for symptoms. We then have to put all the pieces of the puzzle together. So why might it cause symptoms in one patient and not another? It could be systemic inflammation is higher in one patient and not another. It could be that genetically one patient has genes that code for weaker cartilage than another patient, and we're getting wear and tear on that cartilage. It could be because one patient's foramen, where the nerve comes out, is slightly smaller than another patient's, or one patient's central canal, where the spinal cord lives, is congenitally small, and another patient's is wide and capricious. Lots and lots of different factors there. Thin, if ligaments have become lax due to the patient having arthritis, is it worth having PRP, or will the incurable arthritis continue to make ligaments lax all over again post-treatment? I think that's a little bit backwards. So we tend to see degenerative instability lead to arthritis rather than arthritis causing degenerative instability. So the focus is to treat the degenerative instability. And that doesn't mean we're going to make the arthritis new. It just means we're going to slow down the wear and tear that comes from the degenerative instability. Okay, guys, I think we're going to end it for today. We talked again about why does the CMS or why does C1 jump in some CCI patients. I will be here on Monday with a new topic. Thanks so much for all the great questions. And again, the goal of this show is to try to get people's questions answered. I don't know how many hours I've spent now. 100, 200, 300 hours answering patient questions online over the last couple of years. And that's with a singular goal. The goal is, number one, to make sure you can all stay informed. So when things like this Kratom problem comes up, I can get that out there relatively quickly. Number two is trying to make sure that people get their questions answered so that they get educated, because we all learn best by asking questions and getting them answered. So thanks so much. Have a fantastic weekend. I will see you on Monday, and we'll go from there. Thank you very much. Have a great weekend.